Direct from Amsterdam in the Netherlands, you're listening to the first episode of the ECTRIMS podcast, a new scientific sounding board for the MS research community and the official podcast channel of the European Committee for Treatment and Research in Multiple Sclerosis. This October, more than 8,600 MS researchers and experts from around the world have come together in Amsterdam and online for the 38th Annual Congress of ECTRIMS. The objective? To share, to discuss, and to dive into cutting-edge research on the treatment, pathogenesis, and diagnosis of multiple sclerosis and related disorders. Today, we bring you the key highlights of Day 1 of ECTRIMS 2022.
Welcome to the 38th ECTRIMS Congress.
Bridging the gap between basic research and patient care needs a true transitional approach of research.
When I began my journey in pediatric multiple sclerosis in 1999, the question was very front and center. Does MS even happen in children?
MS lesion analysis is always cross-sectional because you get one single pathological snapshot of each donor, typically.
If you could think about one hot topic in MS, one controversial, one argued topic, it's probably escalation versus high efficacy therapy.
We found that if you compare these different compartments, especially in the leptomeninges, but also in lesions of patients with MS, you find an enrichment of antibody-secreting cells.
ECTRIMS hosts the world's largest international conference on MS research, and this year is no different. I'm Brett Drummond, co-founder of MS Translate and host of this special episode of the ECTRIMS podcast. I'm on site here in Amsterdam in the Netherlands, where ECTRIMS has wrapped up Day 1 of its 3-day congress. Today, I'm joined by Brenda Banwell, Professor of Neurology at the University of Pennsylvania, and this year's Keynote ECTRIMS 2022 Lecturer. Brenda, thank you for joining me.
Thank you for having me.
So today you gave a fantastic presentation for the ECTRIMS lecture and talked to us about putting paediatric multiple sclerosis in perspective. Can you share with us why you're passionate about this research and why you think it's important?
Absolutely. So I began this field more than 20 years ago at a time when I had 5 patients total with multiple sclerosis in childhood. I didn't have a lot of knowledge about MS in childhood because the entire literature took me less than a day to read. And at that point in time, there were very few people treating multiple sclerosis in children, no formal programs. The only treatment literature was a case report of an 8-year-old boy treated with beta-seron in the United Kingdom. And we were at the beginning. We didn't even know at that point definitively whether it was truly multiple sclerosis we were seeing. We didn't know anything about the disease course. We had no idea about whether the risk factors for the disease were shared between adult onset and pediatric onset disease. And of course, as I mentioned, we really didn't have a therapeutic landscape. So it's been a very busy 20 years with many wonderful colleagues who have contributed enormous amounts to this field and a very inspirational journey because my patients and their families are truly incredible with coping with this disease at a time when they should be worrying about grade 2. Not about whether or not their therapy is going to work and whether or not they're going to have a relapse the next day.
Yeah, and for those people who weren't able to hear your lecture today, you covered a lot of material and it's been a lot of work over 20 years that you've worked tirelessly on this. But can you share what some of the key messages were from that presentation?
Sure. So the first message is, unfortunately, multiple sclerosis does indeed occur in children. I think the second message is that it is a single disease across the age span. So while pediatric onset MS is almost invariably relapsing remitting in its phenotype, all of the data that we have collected as a community suggests that the risk factors, remote Epstein-Barr virus infection, low vitamin D, adiposity, in children it's secondhand smoke, not smoking themselves, but is also a risk factor. And then the genetic risk factors appear to be shared between pediatric and adult onset disease. So that led to the inclusion of pediatric multiple sclerosis in the 2010 and then 2017 McDonald criteria, which was very important. If you don't have diagnostic criteria that are inclusive, there's a sort of a belief that MS either doesn't occur or that it's different.
Yep.
So I think a huge advance was that pediatric and adult MS share a criteria. There are caveats and things we have to keep in mind, but the criterion are the same. From then, once one makes the diagnosis of multiple sclerosis, that allows you to actually be sure you're studying a group of patients with a shared biology. And that allowed us to then really evaluate the impact of pediatric MS in a variety of ways. So we looked at whether this was an early disabling condition in terms of disability in gait or function, and it's not. Pediatric onset multiple sclerosis patients typically acquire disability after a longer disease duration compared to adults.
Okay.
However, 30% or more have cognitive impairment, and certainly an inflammatory brain disease during primary cognitive maturation and the key building blocks of academic success has a fairly substantial impact. So there's been quite a bit of work looking at the cognitive challenges that my patients face, and very importantly, what can we do about that in terms of advocating for appropriate resources in school. We need to recognize the mental health impact. And at least a third, and I think that number is an underestimate, of pediatric onset MS patients experience some anxiety or depression. And we and others have actually shown that the mothers of children living with MS have a higher rate of depression themselves. And when you put that together, the health-related quality of life of pediatric MS patients is highly influenced by the health-related quality of life of their entire family. Yeah. So just as an adults, when we think about the care providers and the partners of people living with MS, in my world, we need to be very mindful of the parents and the siblings, because the entire family lives with MS.
Yeah, I found that fascinating when you mentioned the impact of mental health, not only of the child living with multiple sclerosis, but also the whole family and the impact that it can have in terms of, I guess, how people need to be thinking about treating this disease. And it's not just the one individual, but it's the whole household that almost needs to be taken into account.
Absolutely. When we first started treating pediatric onset MS patients, our choices were glatiramer acetate and interferons, so all given by injection. And the siblings of pediatric patients sometimes seemed a little jealous of their brother or sister who got to go with their parents to appointments and sometimes came home with extra treats because they'd had a difficult MRI or blood work. And the fastest way to disabuse siblings about their brother or sister having an advantage in any way, shape, or form was injectable therapy, because their brothers and sisters very quickly realized what their sibling was going through, and instead of being somewhat resentful of the attention that the parents needed to provide the child with MS, became advocates and with the appropriate support, really started to become more engaged in helping their brother and sister with this journey.
Yeah. And I think you summarised that really nicely in terms of your journey across the time working on this, talking about the conversations that you had with your childhood patients 20 years ago compared to the conversations that you have now. Can you just remind us of what those are like, and I guess the impact that has on you as someone who's worked tirelessly on this for a long period of time to create this change?
Absolutely. So, I always ask my patients what living with MS is like for them. And when I would make or ask that question 20 years ago, the first answer that all of my patients would share was, well, today's a needle day, or yesterday was a needle day, and today's a bruise day. Or can I take a needle holiday because I'm going to camp with my friends and there's nobody there to give those needles to me, or do I have to miss camp? And of course, I always enabled them to go to camp. But their day-to-day comments were very much about their disease and living with their disease. I remember one of my first MS patients had a jar in her home, and every time she got an injection, she could take a candy from the jar until the dentist had a word with her parents and then suggested instead it needed to be stickers or things that didn't have quite as much sugar. But they had a party for her when she got to her 1,000th injection. She was 8 years old. Yeah. So that stuck with me and has always stuck with me. Now, when I talk to my MS patients who are quite frequently now on highly effective therapy, which is given either orally or by intermittent, often 6-monthly infusions, their answer is to look at me and say, well, what do you mean? Today it's soccer. Tomorrow I'm going to go to a get-together with my friends. They don't even mention living with MS. And it's not that they don't know they live with MS. And it's not that that's not on their radar. But their day-to-day, every single day, isn't influenced by being, so reminded by a frequent intrusion literally intrusion into their body with an injection, and by the feelings that gives them, both the flu-like symptoms that the interferons, result in, but just also the constant physical reminder that they have this disease.
Yeah, and I think that's such a huge impact on what everyone, I guess, that's here attending the conference is trying to have with the work that they're doing. So I think we all congratulate you on your work and the work of others who have worked with you on that journey to create that change. So your presentation would have been a highlight for a lot of people attending today, but for you attending other presentations, can you tell us about some of the other talks that you heard today and what your highlights were?
So I attended the precision medicine session this afternoon because I think this is an interesting direction where we all define that term maybe a little bit differently. One might conceptualize it more as the best medication choice for a given person, which we always want to achieve. I mean, that's the objective of every clinician. But how to do that and what things factor into those decisions. I think several interesting findings came from that series of very nice talks. One of which was the comparison in a real-world clinic setting of hematopoietic stem cell transplant compared to highly effective therapies like ocrelizumab, compared to fingolimod in particular. And without trying to quote someone else's data, I think the interesting findings were that there wasn't a striking difference in disability change, although, of course, selection for the therapies is strongly influenced by patients who have highly active disease and potentially higher rates of disability at the time they actually undergo this treatment. Yep. But there was definitely a strong effect on relapses and visible disease activity favoring stem cell transplant when compared to fingolimod. Not so striking comparison, or actually not at all, when compared to ocrelizumab. So while that's one group's perspective, it does highlight that, a treatment that also leads to hopefully a long-term suppression of disease activity. Certainly seem to do so in a favorable way compared to a fairly effective, at least most of us think fairly effective oral therapy. But that the effect was somewhat similar to a treatment that might be arguably better tolerated. Ocrelizumab has effects long-term that we need to be mindful of, but certainly the experience of a transplant is pretty significant. Yep. And then the questions being asked after that presentation were interesting because the next follow-on question that we would all like to know is what's the lived experience post-transplant? Yeah. The recovery from that experience, the recovery from the chemotherapy that was required to get into the induction stage, the pre-planning for fertility, which is almost always affected, as I understand. I'm not a transplanter, but and then how to mitigate that so that people can move forward with family planning post. And then the fact that most of these patients, as we hope they will be, are not now on other therapies. So what's it like in that stage of their disease journey when they no longer require MS-targeted treatment post this fairly substantial step that they've just taken? So I think those questions were all really informative. Yeah, definitely. It's interesting, having been coming to ECTRIMS for a few years now, how the conversation around these stem cell therapies has changed from should they be a multiple sclerosis treatment to where do they fit into the MS treatment landscape. Do you have any thoughts? It's a very difficult question to throw at you, but do you have any thoughts on what might happen based on, I guess, what you heard in the talk today? I guess my thoughts from the pediatric lens is that at this stage, with fairly rare exception, I don't think stem cell transplant is a pediatric strategy at this point. And I say that because one of the criteria for most of the studies that have deployed the transplants has been people with rapidly progressive disability, which is extremely rare in pediatric patients. So we won't have patients with that experience typically. Now, if you have a patient who's a 15, 16-year-old with highly aggressive MS with very rapid lesion burden and early disability, I would argue that that's the person I would consider it for. Of course, family planning is a big part of that experience. And that's a tough conversation to have with any teenager. But the idea of egg harvesting and, if it's a young woman or sperm banking for a young man, those conversations happen in oncology all the time. Yep. And certainly if a patient is in that situation, I would strongly encourage the team to have an experienced provider who talks about this with teenagers all the time, be the one to have that conversation. Because how you frame things and how you normalize that decision for someone who is perhaps younger than would normally need to make those thoughts is really important to how well they accept it and think about it. But that's a really big part of where that would land for me as a clinician, because it's such a big lifestyle thing to impact at a very young age. For most of our patients, though, with the goal of deploying highly active therapies like anti-CD20 therapy, for example, for JC virus negative patients, perhaps Tysabri, and other therapies that are coming down the pipeline, most of these patients do well, and I think the pivotal studies are hopefully going to strongly confirm that. And maybe we won't need to be in the stem cell sort of transplant stage in pediatric onset MS patients at all, which would be, I think, a lovely outcome.
Yeah, definitely. So was there anything else in that session or other sessions that you went to today that also caught your eye?
Well, I think, in the discussion around precision as well, there was also a presentation around the opportunity perhaps to look at spacing out anti-CD20 therapies based either on repopulation kinetics, which might suggest that some people don't need to be infused quite as often, as well as, maybe looking at the pharmacology of some of the other agents. And, for some patients, they might stick around longer. So there were studies looking at that for natalizumab. That discussion to me resonated particularly when I put on my medical director hat for the Multiple Sclerosis International Federation, where we spend a lot of time thinking about access and fiscal realities. And, of course, all of these therapies are extremely expensive. And for a given person, for some families, a great deal of that expense is out of pocket, which makes it in many parts of the world either unattainable or, fiscally enormously challenging. And just at a healthcare economics perspective, if there's ways to determine what a given person really needs, and we can consider both the cost to them of having to go and receive infusions, but the cost to the healthcare system of spacing those out appropriately if someone is attaining the same level of disease suppression, then that just makes, really good economic sense to me. So I think learning that is valuable. Yep. And I think there's a big role for thinking through how to appropriately proportion therapies for people to achieve maximum benefit and associate that with appropriate fiscal responsibility.
Yeah. I think what's also exciting for patients, I was sitting in that same talk, what's also exciting for patients around that topic is the idea that although we have these highly effective therapies now, we have data and we're collecting data to try and work out how can we optimize their care around those. It's not just we have these therapies, we now use them. What else can we be doing to reduce their risk? So I know they talked about, how do we find the right window to get treatment benefits but reduce the risk of PML with natalizumab and things like that. And I think, using this data once things are out, I think is something that will give patients a lot of hope and enthusiasm as well for the research that's being done and discussed here.
Absolutely. And I think there's a lot of interest in some of the studies that are ongoing right now to look at patients on anti-CD20 therapies. And then when stopped, do they repopulate with the same immune pro-MS, if you will, signature? Or might there be a group of patients for whom after a period of disease remission, the cells that come back maybe aren't educated in an MS aggressive way? And might that mean that some people could have a period of time where they don't require other therapies? I mean, we really don't know that yet, but obviously that would be enormously valuable information, and it won't be everyone, I'm quite sure, but there may be a population of people whose B-cell population returns in a very different way.
Yeah. And so one of the other themes of today that came up in your presentation, and it was one of the topics this morning, was around lifestyle factors. And one of the things that stood out in your presentation was a quote around wellness not just being the absence of illness. And so maybe you can answer this through the pediatric lens again, but we talked about it, or was talked about through for adult onset multiple sclerosis as well, but these factors such as maintaining a healthy weight, conducting exercise. Can you talk a little bit about the research in that area?
Sure. So I do firmly believe that wellness is not the absence of illness. Wellness is itself a therapy that we invest in. And there's literature in multiple populations where if you invest in wellness and health as a child, it carries you forward into adulthood. And certainly the reverse is true. Childhood onset obesity strongly predicts adult onset obesity or continuation of obesity into adulthood. Your eating habits that you grow up with strongly influence the eating habits you have as a young adult, which in turn will influence your cardiovascular risk. We know that MS comorbidities like cardiovascular challenges strongly influence the MS disease course and the morbidity of patients as they age. So in my world, it's partly let's start healthy habits now, so that the entire journey with MS for an individual patient is not also preordained to be complicated by comorbidities that we anticipate will make their disease worse, for one. Second, there's good data on the importance of exercise. Dr. Ye and others have led this work, showing that exercise improves wellness in absolutely everybody, pretty much, that engages it or who can engage with it. It improves self-esteem. It improves and reduces depression in many people. There's some early studies suggesting that it might improve hippocampal size. There's a strong literature in the pediatric population that regular exercise improves engagement in school. It improves healthy sleep. So there's a great deal that it has the potential to improve, particularly at a time when the brain is vulnerable, living with a disease like MS. So exercise is important for everyone, but it's important to start young. Vitamin D nutrition. We know that low vitamin D links to MS risk. I am aware of absolutely no literature that having a healthy vitamin D level is bad for you in any possible way. But vitamin D, has the potential to be important as a disease-modifying component. That's a hard thing to study, but I think low vitamin D levels reduce bone health, muscle health. Animal models strongly suggest that low vitamin D is permissive to a more aggressive immune response. So certainly targeting healthy vitamin D levels seems like a good investment in health anyway. So we strongly encourage that. Of course, if you have food security and good nutrition and you're physically active, you're much more likely to also have a healthy body weight. And obesity is a risk factor for MS. It is adipose tissue is a pro-inflammatory tissue all on its own. And there's data I didn't have a chance to talk to today, which relates to adipokine biology and the fact that there may be some very pro-inflammatory adipokine signatures in MS that we hope would be mitigated by healthy body weight. Okay. So in aggregate, I think starting healthy lifestyles as one of the things you can control while you live with this disease that you don't have complete control over, I think is empowering.
Yeah, definitely. And I guess we have a lot of data now that was also talked about today, showing that the earlier people can get on highly effective therapies, the better their long-term outcomes. And theoretically, maybe the same is true for these lifestyle modifications and doing these things like exercise, improving diet. It makes sense potentially that doing them from a young age, the earlier we can get people into these habits, the better their long-term outcomes are as well.
Well, certainly, I cannot imagine data showing the opposite. So, the common sense approach sometimes actually gets lost in translation. But, I think my pediatric MS patients have taught me a myriad of things. But they've also taught me about how they've coped, and they've talked about what they have done to contribute both to their own life in terms of living with MS and to that of others. And a theme that emerges through that is knowledge, some degree of control and empowerment, telling their own story and telling it to the people they want to share it with. One of the things that's important when I first share the diagnosis of MS with a new patient and their family, before they leave on that very first visit, I actually have them sit down and say, please talk in the car on the way home about who gets to hear about this news. Yep. Because it is the teenager's story. They do not like it when their parents share that story with their neighbors, their coworkers, their grandparents, their relatives, anyone who will listen and provide support and sometimes information, well-meaning but not always necessarily ideal. But parents do that invariably. They look for other sources of comfort and feedback and share this news often quite widely. And the teenagers in particular share with me that that's one of the things about living with MS they like the least. And at a time when a family needs to be together, it pushes a family apart. So once a teenager has accepted that they live with MS and are ready to share their story, I have had my patients become leaders in MS chapters, One of my patients was the youngest ever MS chapter chair. They attend things, they do things, they communicate with each other. So I think when they're ready to go down that journey in a more public way, they're very keen to do so. But it is a really important conversation, and I'm very proud of the patients that have been able to turn around and say, I'm not ready for this. I can tell one or two people, but I really don't need everyone I know to know that I live with MS, not because I'm ashamed of living with MS, but because I'm not ready to talk about living with MS every time someone comes for coffee.
Well, communication seems like a perfect way to finish our first official ECTRIMS conference podcast. Thank you, Brenda, for your time, firstly giving the fantastic lecture today, and for your time to record the podcast. Thank you, everyone, for listening. Please join us tomorrow as we continue with this special ECTRIMS 2022 series, highlighting all the essential research elements of the day. As a reminder, you can subscribe to the ECTRIMS podcast on all of your favourite podcast channels, including Apple and Spotify. Visit the official ECTRIMS 2022 website to learn more about the ECTRIMS Congress and join the conversations on Twitter, LinkedIn, Facebook and YouTube.